All right, we will get started again. So, welcome back. This is our final session of the day. So each year, our keynote address for the ATI Research Day is generously supported by the Lakey family through the William H. Lakey Transplantation Lectureship Fund. Dr. William H. Lakey was a founder of organ transplantation in North America, performing Alberta's first kidney transplant in 1967. In honor of a wonderful husband, father, grandfather, and colleague, the Lakey family established this lectureship fund that has become a centerpiece of the ATI Research Days and allowed us to bring in renowned speakers from across Canada and internationally. We are joined online today by Dr. Lakey's wife, Shirley, as well as members of his family. The ATI is very grateful for the ongoing legacy the Lakey family has created in memory of a brilliant surgeon and a mentor to many still practicing here today. So our keynote speaker is Dr. Mamatha Bhat, who is a hepatologist and clinician scientist at the University Health Network's Ajmera Transplant Center, scientist at TGHRI, and associate professor of medicine at the University of Toronto. Dr. Bhat completed her medical school and residency training at McGill University. She then completed a transplant hepatology fellowship at the Mayo Clinic in Rochester, Minnesota, and followed by a CIHR fellowship for health professionals, through which she has completed a PhD in medical biophysics. The goal of Dr. Bhat's research program is to improve long-term outcomes following liver transplantation by developing tools of artificial intelligence, integrating clinical and omics data, and has been funded by CIHR, Terry Fox Research Institute, Canadian Liver Foundation, American Society of Transplant, among others. She has published over 155 papers in journals such as The Lancet Digital Health, Journal of Hepatology, JAMA Surgery, Gut, and Hepatology. Dr. Bhat has been the recipient of recognitions such as the 2022 Castle Research Excellence Award and the 2021 American Society of Transplantation Basic Science Career Development Award. Dr. Bhat is also director of the Clinician Scientist Training Program in the Department of Medicine at the U of T, partnership and engagement lead for the Telemetry Center for AI Research and Education in Medicine, and past chair of the International Liver Transplant Society Basic and Translational Science Research Committee. The title of her talk today is Optimizing Equity and Outcomes Post-Transplant Using AI. So a big round of applause for Dr. Bhat.
Good afternoon, everyone. Thank you so much to the organizing committee, Dr. Mengel, for the kind invitation to present here and the kind introduction, Dr. Bhanji. So it's really my pleasure to be here with you today at this excellent research day. Really enjoyed the presentations by all the trainees. Really demonstrating the breadth of work that you're carrying out here at the Transplant Institute. So in my presentation, I'll be going through several transplant scenarios that have inspired work by my research team, and it's a highly interdisciplinary research team. So half of my team is comprised of computer science, experts, as well as trainees, so postdoctoral fellows and graduate students. And the other half, is comprised of bioinformatics, as well as clinical fellows. So it's highly interdisciplinary. There's also one member who's more on the wet lab side. So it's highly interdisciplinary, and everyone learns from each other. And so we grow the knowledge together. And I've built very significant links and collaborations with colleagues across the Department of Computer Science, as well as machine learning across the different Toronto area hospitals. So let me just get started here. Okay. So here are my disclosures, okay, including industry as well as peer-reviewed grants. So I'll start off with what is AI. Generally, I think we got a bit of a sense of that, with the excellent talk just before mine. But I'll give you a sense of the current healthcare applications. And then particularly then focusing on transplantation, we'll focus on liver transplantation, given that I'm a hepatologist. So, but certainly you will have seen, excellent work, outstanding work by people like Dr. Alex Lupi, among others. But really, Dr. Lupi has led the way in transplant and particularly in kidney transplant. I'll then get into specific scenarios that we focused on, really inspired by clinical questions that have come up in my practice. So I'm a clinician scientist, and so 75% of my time is dedicated to research and 25% of my time is clinical. So that means I do, basically a few weeks of inpatient service a year, and then I also do post-transplant clinic and assessment clinics. So 25%, and then the other 75% is research time. So the nice thing about that is that that really inspires the questions that we look at in my research program. So we'll go through the waitlist, dynamic trajectories, post-transplant patient survival, as well as graft survival as some case examples of the breadth of areas wherein machine learning can be helpful. So what is AI? First of all, it's basically intelligence demonstrated by machines and computer systems that use information and act in a goal-directed manner. And so you can see here various applications of AI in the healthcare system, including AI-assisted robotic surgery and medical image analysis. So medical image analysis has been particularly the sort of leading aspect of AI in healthcare. There are various other applications, including in the insurance, health insurance area as well, but really the breadth of applications is in the upper right-hand corner here. What is machine learning? So machine learning is a subset of artificial intelligence, and it's about learning equations from data. So it allows software applications to become more accurate at generating predictive models without being explicitly programmed. And this allows for detection of hidden patterns and interrelationships within large data sets. So then if you look at deep machine learning, deep learning is about learning complex equations from data. So you have multiple parameters, and then you have different layers of data to model and solve complex problems. So including the classification of skin lesions, text to image generation, conversational agents such as ChatGPT, and then protein structure prediction for those of you more on the basic biochemical side. So why is that last example particularly interesting? So as many of you will be aware, a few years ago, there was a very interesting tool developed by some stellar scientists at Google DeepMind, so John Jumper and Demis Habbis. And they developed this deep learning tool to predict the 3D protein structure based on amino acid sequences. And they were able to do this in a very accurate way, such that the pharmaceutical industry, it really took the pharmaceutical industry by storm. And so within a few years, in fact, these individuals received the Nobel in chemistry on the basis of their transformative work with AlphaFold. And so that was last fall. And then also a Canadian story is Jeff Hinton winning the Nobel for physics for his pivotal work in deep learning. So many of his mentees are across Toronto, but then also worldwide. Okay, so what are the three main paradigms of machine learning? So you have supervised learning, wherein you are predicting labels from data. So you have a large data set that is labeled. Okay, so you have a lot of data that is labeled. So it belongs to this category or that category. So this is an example, a very simple example. Of a chest x-ray with pneumonia or without pneumonia. So basically you have a large data set of several thousand radiographs, and then you are teaching the model to say, okay, is this pneumonia or not? Okay, and then you then give a test set, and then you see how well the model performs in predicting the label on that new data that is shown to the model. That's supervised learning. Then you have unsupervised learning, which is learning representations of the data. So if you're thinking about, say, transcriptomic data or arrays, so you could have various categories of liver cancer or whatever condition you're interested in that are learned by the model. So it's learning representations and labels from the data. That's unsupervised. Then you have reinforcement learning, which is about dynamic decision making using data. So in gaming, for example, they use this concept about giving a reward every time there is sort of a positive action, then there is a reward. And so based on that, the model learns that this is actually how the model can increase its performance. So drug dosing practices can be informed by reinforcement learning. Another interesting paradigm, and this is actually a figure taken from a review that we published last year in Gut. This is a review on AI applications on omics data in liver disease. And this may be very interesting for those of you who work with omics data at your own institution. So if you think about, say, institutional data sets, single institution data sets, they tend to be very small. So how can you do machine learning on such a small data set? It's not possible to train a model on very small data sets. So what you can do is then train your model on a very large data set that is publicly available and has similarities, some overlapping features with your own data set at your institution. So you train the model on that outside data set, and then you bring that model and then fine tune it on your own data. So that's called transfer learning. Okay, so people have done this many times, say with the TCGA. We have an example of a paper. I don't talk about it in this presentation, but basically we use the TCGA, the Cancer Genome Atlas, to train on liver cancer data, and then brought that to then train on recurrent HCC post-transplant data. So to fine tune the model and increase its performance. So you can do that kind of work, which is called transfer learning. Okay, moving on. So why machine learning in transplant? So in transplantation, we are dealing with a very complex patient population. There are a lot of data points, clinical data, laboratory data, longitudinal data, trajectories in the data, dynamics. Okay, so a lot of data that we, on a day-to-day basis, when we see a patient in the clinic, we're trying to piece together all that information. There are patterns in that data. Now, the human brain can deal with 7 variables at a time. It can't really deal with many more than that. So how can you deal with, say, 160 or, several variables, several more variables than that? So we try our best to generate personalized predictions for the patient in front of us. We will do a reasonable job as we gain experience, right? So the more and more patients you see, you have your own subconscious algorithm in your head. Okay, this is, probably for this patient, this is the best avenue. This other patient, this is what I need to do. Okay, so you sort of develop your own, decision path. Now, the reality, again, is that the human brain cannot deal with more than 7 variables at a time, notwithstanding longitudinal changes. That's the other thing. I will often, in the post-transplant clinic, I will look at, what has been happening to this patient's creatinine and GFR over time. I have my patient on tacrolimus. This is my trough level. And it seems like every year their GFR is, going down further and further, right? So, But if you don't actually look at those trajectories, you can lose sight of that. So anyway, so we're constantly looking at patterns in the data, trajectories, various different factors, and newer data, imaging, histology, etc. Right? So how do you bring together all of this data? How can you really, bring it all together and generate a personalized prediction for the patient in front of you? So the reality is that we can, with AI tools, do much better. Additionally, there is the potential to bring objectivity to certain complex decisions. So there are many decisions that we make in transplant that could be a bit more objective. So certainly decisions that we make at the transplant selection committee in terms of donor organs. What is the optimal donor organ for this specific recipient? There is going to be interinstitutional and inter-physician variability in the way these decisions are made. And that's not ideal for the patient, right? And it may not be ideal for the program. There may be a more objective way of doing this. So a surgeon may be biased by something that happened recently in the OR a few weeks ago. So that sort of bias can creep into certain decisions that are made, and these are life and death decisions. So we need to be more objective. There's the ability also to bring more objectivity to basic science experiments, and I don't talk about that here, but with deep ML, with sort of vision, transformer models, you can do much better in terms of making the analysis of data the most objective possible. And that figure was from a paper that we published in Journal of Hepatology a few years ago. So it's a review article on AI and liver transplantation. So now I'll move on to a few examples in the transplant arena. So this particular work was again inspired by the interest in AI agents. So in industry, there's been a lot of talk about AI agents over the years. And then last year, I thought it would be very interesting to run a sort of pilot study based on the concept of AI agents. So I was interested in simulating how a transplant selection committee might work. So we had a large language model representing each subspecialist on the transplant selection committee. So one LLM representing the hepatologist, one representing the surgeon, another representing anesthesia, another representing social work. And then we, using prompt engineering, and this was in OpenAI, using OpenAI, we asked, we gave a case to a hepatologist and then asked what their opinion was about this patient's candidacy for transplant. And then we asked the same of each of the subspecialties. Then we asked the whole committee, all 4 LLMs, what are your thoughts on this patient's candidacy and why? Okay, so what is your rationale for yes or no? Okay, so we did that for over 8,000 cases that we had generated using the SRTR. And then also using some standard absolute contraindications to transplant. And actually the AISC, or the AI Selection Committee, was able to accurately waitlist liver transplant patients based on their 1-year survival. So we use that as the outcome because, again, the SRTR doesn't have patients who have been officially declined for transplant. So we had to sort of, use a surrogate of who would or wouldn't be the optimal candidate for transplant. And so we use that just as like an experiment. So we were interested in seeing whether an AI selection committee could, say, potentially provide an objective voice on the selection committee. So, anyhow, this is a proof of concept which could be considered in future. Okay, so now I'll move on to inequities in liver transplant allocation. And this is a grant that is funded by the Canadian Institutes for Health Research. Rahima is a co-applicant on this and collaborating with us on this project. So we know in liver transplant allocation, there have been certainly inequities, disparities on the liver transplant wait list worldwide. One particular group that has been disadvantaged over time is female patients, and that's because of a range of issues. There is additionally a disadvantage to patients with PBC because the bilirubin is underweighted in the MELD 3.0, in the MELD scoring system. Additionally, over time, there are dynamics on the liver transplant wait list, and there have been shifts in the cohort. So the dominant population in 2002, when the MELD was initially developed, was the hepatitis C population. Now it's more MASH and alcoholic liver disease. So those are the dominant indications for transplant. But certainly autoimmune liver disease patients are lesser in proportion and relatively disadvantaged, less able to attract an organ offer. So because I was seeing this in clinical experience, it prompted me to look a bit into the literature, and then I realized, okay, well, this is something that we very well could look into using machine learning. So then what we did was, and this is in close collaboration with Rahul Krishnan, who's a computer science professor at the University of Toronto and led by his PhD student, Michael Cooper. So Michael trained a deep serve model, which is a deep machine learning version of a Cox-PH model, on over 53,000 patients listed for transplant in the US since 2019. These were patients with decompensated cirrhosis and without exception points. And we considered 13 static and time-varying covariates. Now, what he did beyond the standard deep serve is actually added on rates of change. So first and second order rates of change, meaning the velocity as well as the acceleration of each of those blood tests on the waiting list at every single time point on the waiting list. And by doing that, actually, we achieved better concordance. So we were better able to prioritize patients based on their severity of illness as compared to the MELD 3.0 and the MELD sodium, as you can see here. And then we looked at fairness. So we looked at the pooled group concordance index, which is a measure of fairness. And this is the concordance over pairs where the first member is a member of a protected group, defined protected group. And looking at that, women, PBC, and small statured patients would be better served by our particular model, as you can see here. So better ranked. Now, we then moved on to interpretability. We were interested in seeing what were the main features that were predictive in terms of mortality and dropout on the wait list. And this is for the overall population, and we can also do it at the individual level, which I'll show you later. But for the overall population, reassuringly, the top parameters there you can see are components of now the MELD 3.0, which includes now sex and albumin. This was added on just last year. Over 1.5 years ago. But traditionally was not, right? But these are the top for the overall population, and each point represents a patient, okay? So then when we look at the lower features, what we see is that the first order change, or the velocity in a patient's serum sodium, creatinine, albumin, bilirubin, and INR are actually pretty important for a subgroup of patients. So a subgroup of patients have something called acute on chronic liver failure, where their risk of mortality is actually going to be higher than what their MELD suggests at any given time point. The fact that they've had a rapid increase in their blood tests within a very short period of time actually means that they're much sicker than their MELD, absolute MELD score actually, suggests. So we see that here. And the fact that someone has PBC or PSC also is an important factor. Okay, so all of those factors are actually important for a certain subset of patients. So we might be currently doing well for the overall population, but there are various subgroups of patients that are getting disadvantaged and left behind. So this is why, this is of particular interest, this kind of approach. Now, what we can do now is then individualized interpretations for each patient. So you can then understand what the weight of each of those features is in a given patient's risk of mortality or dropout. So, their serum creatinine at a given point in time might be a positive or a negative predictor have a certain weight. So you can see what is the weight of those independent features on that prediction. And then you can see that dynamically. So here, this is an example of a 50-year-old lady with PBC. Basically, you can see earlier on, the fact that she had PBC was the most important factor. So the first two, at 26 and 88 days after listing. But then at 132 days after listing, the fact that she's now on dialysis is actually the most important predictor of her risk on the wait list. So this is very helpful, could be very helpful for physicians as well as patients to understand, what is driving my risk, and is there anything we could do to address this and, help this patient while they're awaiting an organ offer. So this is where I think, we have this potential to really model the dynamics of a patient on the wait list. And so now what we have done is actually integrated this model into a dashboard on Epic. So I'll show you we have just completed a silent trial on patients waitlisted in our program from June 2022 to November 2024. And this is just an example dashboard, so it's not a real patient. But basically, we had a data engineer, so we're very fortunate through the Transplant AI initiative to have a data engineer who's able to integrate such a dashboard and facilitate the flow of data directly from Epic to a cloud and then through the dashboard every time you want to generate an individualized prediction. So there you can see that for this particular patient, you can see their dynamics on the wait list, and then what is their relative risk compared to other patients on the wait list, and then what are the features and the weight of those features on their risk. So I should also say we did then a reclassification analysis, et cetera. So, the silent trial did demonstrate to us that Dynameld is able to reclassify disadvantaged groups into higher risk tiers much better than the MEL 3.0. Okay, so that's for that project. Now I'll talk to you a bit about this particular project, which is simulating a clinical trial. So what we were interested in doing here was to compare the survival benefit of living donor liver transplant versus deceased donor liver transplant recipients. And we were interested in seeing whether access to one versus the other, having matched 4 different factors, so sex, age, indication for transplant, et cetera. So whether matching for those, using a particular approach called decision path similarity matching, would be able to give us an idea of an individual patient's survival benefit. And so the machine learning analyst or postdoctoral fellow working on this was Ani Gangadhar, and he collaborated with a surgical resident, Bima Hashim at UC Irvine, who's been working with my group in the last year. And so they together worked on this particular project to then generate individualized prediction of survival benefit. And the QR code for this paper is here. It's almost accepted in a journal, but basically we'll provide further details as to how we did this project. But basically it's allowing us to simulate how a randomized clinical trial would appear without having to do it, so using observational data. Okay, so now I'll move on to the post-transplant patient survival aspect. And so we know that for liver transplant recipients, we could actually do much better in terms of long-term survival. So although 1-year survival has dramatically improved in the last 30 years, survival beyond a year post-transplant, certainly we could do much better in this regard. And the reason is because patients come in with existing comorbidities, but they're also exposed to lifelong immunosuppression. And this increases the risk of cancer, cardiovascular disease, infection, and cirrhosis due to MASH. And so how can we change this and turn transplant into a cure? And so we published a paper a few years ago. This was a study that was really inspired by this. So the idea was we wanted to be able to predict survival and what were the aspects of a person's, say, health that were compromising their survival. And so we considered longitudinal data. We trained on the Scientific Registry of Transplant Recipients as our training set, and then the UHN data set as our test set. And our best performing deep machine learning model was a transformer model with an AUC of about 0.8. And then we went on to test this on the UHN data set, and the performance was quite similar, although the overall Shapley analysis, so the features that were predictive of the survival, were different in the two groups. So then what we wanted to do was then implement this algorithm into the clinical setting, and we came across several obstacles. We realized that a transformer model or a deep ML model was quite heavy for our system to accommodate. And we were getting unusual predictions. So this was in the silent phase. We were getting some hallucinatory predictions. So we realized, okay, now we need to make this much simpler so that it isn't as resource intensive. And so we pared down the model, and we retrained a new model actually to predict the risk of cardiovascular events in liver transplant recipients. And so then we then had to develop this model, and then finally now we have a model that is in the silent testing phase, again within Epic. So our data engineer was able to build this into Epic, and again this will show you that this particular patient's risk, CV risk, cardiovascular risk, can be predicted over a 1 and 5 year period, and then it identifies what are the ranked features that are contributing to that risk. And there are certain modifiable versus non-modifiable risk factors that you could then try to address in order to optimize their trajectory post-transplant. So right now what we're doing is working on the implementation side of things to run a prospective assessment of this tool in the clinical setting and see how it informs physician behavior. Okay, so now I'll get into the last part, which is looking at graft survival. And I think, again, just to highlight that it is possible to develop new methods, new tools. So, you know, the tools, some of the tools that we have developed are really designed for the specific clinical nuances. So the nuances of a clinical question, as well as the data set. So, and it's possible to do that by working very closely with computer science colleagues, or if you have that expertise yourself, you know, on your own team. So, which is how all of these projects have been feasible. So this project was driven by a postdoctoral fellow on my team, and in close collaboration with a colleague at UHN, Wei Zhu, and also a clinical fellow who worked closely with Divya Sharma, the postdoctoral fellow. So basically she trained a deep machine learning model, a variety of deep ML models on several laboratory and clinical features longitudinally over time to predict 1 and 5 year risk of graft fibrosis. So stage 2 or greater fibrosis in liver transplant recipients. And she realized that the model wasn't really performing optimally. So she used different types of deep ML models. One of them was long short-term memory network, but she realized it wasn't performing optimally. So she then decided to include something called a weight loss function in order to improve the performance of this tool, because there were missing data points longitudinally in certain patients. And so by doing that, she was able to help the model better predict 1 and 5 year risk. And additionally, it was able to upweight the training on cases versus controls. So by doing that, this particular model, which is called weighted LSTM, and it was a new method that was developed by our group, achieved an AUC of 0.798 for the prediction of 1 and 5 year fibrosis, significant fibrosis. And then here also you can see the top ranked features. Now we're extending this model. So this was published in Lancet Digital Health 2 years ago, but now we've been extending this model to create a more multimodal model. So incorporating clinical and laboratory data along with text reports of ultrasound so different types of data to then predict 1 and 5 year outcomes. And that's, I think that would be very helpful from a clinical standpoint to then guide optimal clinical care and optimal graft outcomes. Okay, and then this is one of the last projects I'll talk about. So it's called Graft IQ. So it's a diagnostic tool for graft pathology. So if we look at liver transplant recipients, over 50% of transplant recipients along their post-transplant journey will have elevated liver enzymes. And so what the liver physician does is often look at those patterns in the data. Okay, ALT is greater than AST, and then alkaline phosphatase is elevated, bilirubin is or isn't elevated, and then they also have bone marrow suppression. And then I recently changed their immunosuppression a few weeks ago, or maybe I stopped their prednisone. So, there are different moving parts, and you try to consider all of those things. Okay, the age of the recipient, etc., indication for transplant, all of these things we have in our mind, diabetes status. And we will generate a pretest probability. So before doing a liver biopsy, because the reality is that, okay, we order an ultrasound, it may take a few days for that to get done, and then a liver biopsy after that. If they're an inpatient, that'll get done more readily, but as an outpatient, things are a bit slower. So the reality, however, is that we tend to have our own predictions, and then we tend to change the management of the patient based on what we think is the likely diagnosis. So before we have the test result, because we want to do something. When we see elevated liver enzymes, you kind of want to do something, right? So, but that might not be ideal. Additionally, a liver biopsy is invasive. And so again, as I said, if the physician will have a hunch based on the patient profile and test patterns. And so for a young patient, autoimmune disease was the indication for transplant. They have elevated liver enzymes in this particular pattern, most likely to be acute cellular rejection or T-cell mediated rejection. So what we did was we developed, again, Divya was the one who drove this. She developed a multi-class artificial neural network trained on longitudinal clinical and laboratory features over the week prior to the liver biopsy. And so we considered over 7,000 liver graft biopsies performed at our center and generated a multi-class artificial neural network that was trained on the 6 main categories of liver graft pathology. So the AUC of this ANN was 0.866, which is pretty good. Now, what we did then was we compared the performance of that model versus the medic, and this was an experiment. So we asked physicians, transplant physicians as well as fellows, to review 30 cases and say, okay, what is your most likely diagnosis? And actually the model performed better than the medic. However, it didn't perform very well in the prediction of acute rejection, which I found very strange because I would have thought that that would be very intuitive. And so I looked at the cases where it wasn't learning things properly, it hadn't predicted properly, and I found it surprising that it wasn't recognizing, some of the things that would have been very intuitive to me. So then I asked Divya, okay, can you feed some of these clinical decision rules back to the model? So bring the human into the loop. And so she applied Bayesian inference principles to fuse the prior knowledge provided by clinicians. So basically the sort of clinical decision rules. And then in fact, by doing that, by integrating the weighted combination of probabilities of the ML model and the clinician, we achieved better performance. Then we had submitted this paper back in October, and then we got the comment back, well, you haven't done external validation. So then we said, well, we only have 3 months to resubmit this. They're asking us to resubmit this with external validation in 3 months from now. So what do we do now? So we had a data transfer agreement with Hanover. So we got data from Hanover for external validation, and we tested the model on that data. But then we also thought, okay, just in case that data doesn't come through in time, what we will do is now send the code over to Mayo Clinic. So just very recently, now at Mayo Clinic, I have a colleague, a hepatologist, who's also done some machine learning training. And he's able to extract data from Epic and also run models. So basically, we sent him the Python notebook and we said, okay, could you please test our model on your data? So over 1,500 biopsies. So that's how we did that. And then same thing in Singapore. So a transplant hepatology fellow graduate from our program had just started last year, and she had a data engineer whom she had gotten through a grant that I helped her with. And then basically, you know, she now has a data engineer, and which is great now. So we just sent the code there, no data transfer business, which takes a very long time, like a few years, you know, and it's very difficult, right? So this was the easy way for us to get it done. And the reason we did this was because we had to deal with these revisions very quickly. And we already had the paper in medRxiv. The code was on GitHub. So basically we transferred the code and that was it. And they knew what they were doing. So it requires someone who knows what they're doing on the other side. Our algorithm validated very well at those other centers. And so achieved comparable AUC, at Mayo, so in the range of 0.83 for most of the categories. Hanover was a bit lesser, and then Singapore also, so 0.7 or so. You know, so it was pretty good, but it wasn't as good, and we have to figure out why that was, like what might account for that, but it was still pretty good. So it validated it was generalizable, which is pretty unique in AI in healthcare, because most tools end up not generalizing outside your own institution because there are different environmental factors that will prevent that from happening. Okay, very briefly to conclude, so we are also working with molecular data. So my background is in the wet lab and bioinformatics, actually. So I thought it would be very interesting to look at methylation patterns on circulating DNA to see whether there was anything that could distinguish patients with MASH versus rejection. And so we looked at DMRs, or differentially methylated regions, on circulating DNA in patients with NASH, and found MASH, and found that DMRs were associated with lipid metabolism with lipolysis function in patients with MASH. And this is pilot data from UHN. We are now validating this in the Hanover cohort of 90 samples. So we do have analysis that will conclude in 2 months from now. This is 19 patients with ACR with rejection. And again, the DMRs were associated with PDGF signaling. Then what we did, the next step was basically integrating the top 148 DMRs. So we did basically dimension reduction to deal with only the top 148 DMRs, and integrated those with, and this was driven by Mamatha, who's a postdoc in AI on my team, and basically integrated those DMRs along with clinical variables, so age, sex, diabetes status, and different liver enzymes. And basically, by doing that, we achieved very good classification. So with 95% accuracy for rejection and 82% for MASH. And you can also identify by SHAP analysis what exactly the factors are that are contributing to those classifications. So yeah, so this is an interesting sort of integration of omics as well as clinical data for precision care of patients. So overall, you know, in summary, basically, you know, I think machine learning models can be developed for specific clinical indications based on, you know, the inspired clinical experiences that you have. So say, for example, the Dynameld case that I spoke about was really inspired by my own clinical observations, and the same for the other ones. So, you know, you should try your best to identify problems that are important in your field and see how you can collaborate with, great computer scientists. If you're interested in AI in your research, connect with people at the Alberta Machine Intelligence Institute, right? And then see what are specific skill sets that could be of interest to your own projects, right? So that's how, and you have a world-class institution right here, just a few blocks away. So really a great opportunity to bring AI into your work and do very interesting, things that are a bit different, and I think can lead to very interesting observations. I think AI models can help you identify very interesting patterns and hidden interrelationships in data, whether it's clinical data, omics data, histological, or radiomic, whatever it is. There's the opportunity to develop dynamic models that also, can best simulate the dynamic trajectories of patients. People are also looking at other frontiers, which is lifelong learning, so looking at models that can learn by themselves over time, because there is a risk of data drift and model drift accordingly. Additionally, multimodal AI, AI agents, clinical trials of AI tools, all of these are the next frontiers and, very emerging and happening areas in AI and healthcare, and certainly we can bring these to the transplant arena. I'd like to acknowledge members of the Transplant AI Initiative, and this has only been feasible through the support of our transplant programs, so our transplant leadership. Dr. Humara, actually, when he was transplant director, really supported this, and then now Dr. Kumar has followed up. And so I'm co-leading this along with Aman Sidhu, Dr. Aman Sidhu, who's the lung transplant program director, and Mike Brudno, who's chief AI scientist at UHN. Several students and trainees representing a breadth of disciplines and key collaborators. So I'd like to acknowledge all these people and welcome any, opportunities to collaborate and trainee postdoc interest. And I'd like to acknowledge our funding sources as well. Thank you so much, and happy to take questions now.
Just wanted to say great talk, very interesting,
Thank you.
Lots of new things to come.
So I found this particularly pleasant to listen to compared to most AI lectures.
Oh, thank you.
And if you, wait a minute though, hear me out. So think of what you would have said when AGI is fully here in 2027, or artificial superintelligence in 2030, because then you would have had to acknowledge every 30 seconds that we're now beyond the cognitive ability of humans, and the new discoveries come from machines, and they are things we never could have accomplished. And because I was missing from your talk, we all felt so proud to be human doing this great AI stuff, and we totally have agency, and we're in charge of everything, and it's just so fantastic. And that's what most AI talks already give you a bit of uncertainty of how long humans will be in charge. You didn't do that. And maybe you don't believe that, but what do you see happening? I mean, don't you think that progressively the new discoveries, you and I and most of the people in this room will not be able to understand, but we still benefit from them because they come from a superior intelligence? That was the idea missing, maybe because you don't believe it, right? So, yeah.
That's a very interesting comment and question. I think, for now, And who knows what the future will hold. I mean, I have trouble keeping up, to be honest. I have trouble keeping up in terms of what's going on in AI. And it is really tough to keep up. So, yeah. The only, yeah, I mean, the reason I can sort of keep up is because my trainees keep me up to date. So I have postdoctoral fellows and computer science graduate students, and I interact very closely with computer science folks. So I'm sort of, I know what's going on in that community. So I would say overall, as a clinician scientist, right now, my sense is that AI tools will be used only to enhance our care. So it's difficult to say, to be honest. Depends on the sphere of work, I think. So I think that everyone has to retool and reskill, given the rapid changes that have been occurring. So I think the reality is that any medical students who are coming through do really need to understand what's going on and do need to have some part of their curriculum covering AI tools, because the reality is that they are going to be interacting with those tools on a day-to-day basis. Now, healthcare has been very late to the game as compared to industry and business. The reason for that is because, people are concerned about the safety and reliability of tools. So I think, we really do need to assess the safety of these tools in prospective studies and clinical trials. As I mentioned, with the very simple example that I gave, the transformer model, it gave hallucinatory predictions. So I wouldn't be able to use that safely. So I think that the day when we're completely replaced by AI agents, I don't really see that happening, but there are many jobs that will be replaced by AI agents. Like there are certain administrative jobs, certain types of jobs that could be replaced by AI agents. But I think in healthcare, at least for the forthcoming future, I don't see that happening.
So what I have said
Yeah.
in a published paper is that medicine will be completely in the hands of machines.
Yes.
In 90 years. And that's not challenging you, see, because you're not planning to be still practicing that. So that
well, I don't know. I don't think any of us knows what the future will bring. So it's very difficult to predict. But
that's very general.
Yeah.
And I think you can see it coming at some point.
Yes.
That machines will be in charge. Now, Rich Sutton, who's from this city.
Yes, reinforcement learning, yeah.
Won the Turing Award, which is the Nobel Prize equivalent.
Yes.
He believes in this automatic world, and also that there are no human authorities in science.
Yeah.
If you believe,
I mean, Jeff Hinton also has been very concerned about this, yes.
That you must always follow. He says, no, there are no human authorities in science.
Yes.
And he sees an automatic world not run by humans, which would be ideally suited for us.
But I would follow up on that, ethics on that. So how would your model learning to allocate organs? Who decides what the priority is to allocate an organ? So we have not enough organs. Not everybody gets one.
Yeah.
So is it survival on the wait list, so to say? Is that the priority? Or is it survival when you have an organ?
Yeah.
So do you really want a machine to decide that? Because that's an as Elon Musk says, the biggest weakness of humans is empathy, right? So where is the empathy? Whether somebody, because when you say post-transplant survival is the criterion, so give healthy young organs to healthy young people, then we have super long-term outcome, right? But where is the decision point? And this, you can't train a model on that. You can tell a model to be trained on saying, we want the best post-transplant outcome. But is that the priority to be trained on? So how do we have, or do we want machines to set priorities, what's right and wrong in healthcare?
Yeah.
That's rather the question.
In terms of liver, just to clarify, from the liver standpoint, in fact, we just rank patients based on severity of illness on the wait list. We don't consider the likelihood of post-transplant benefit. We don't actually, like once we have listed someone, we don't then look at post-transplant benefit. The decision to list someone is based on whether we think that they are likely to derive a post-transplant benefit, but the prioritization on the list does not depend on consideration of post-transplant benefit. I know in lung transplant it's different, but in liver we have not yet done that because there haven't been very good, say, proposals of that at the UNOS. And so, I mean, what we could do as an extension of the Dynameld is then include consideration of 1 and 5 year survival. So 5-year survival, yes, we do consider 5-year survival in determining candidacy for liver transplant, but we don't use it as a way to determine rank order of patients.
So that's a convention.
That's a convention that the transplant community has decided.
United Health might want a different convention.
Yeah.
Right, what they pay for.
Yeah.
So that, I think it's very dangerous who controls the priority setting what a model is trained on when you use it for such ethical dependent decision making.
I think that this will have to depend on a society's values, like whether they think that something is of value or not. So looking at the post-transplant benefit. So you could consider, incorporating the post-transplant survival benefit into the model if that's something that the society believes in. So you could, and then the other thing is also considering what is the local organ supply versus demand, So kind of fine-tuning models to consider the local circumstances in terms of organ availability. In Ontario, we unfortunately have 25 to 30% waitlist mortality, which is unacceptable. Our liver transplant waitlist mortality is 25 to 30%. So now we are looking at strategies to improve the access of organs using perfusion, etc. In some places in the States, they have almost no waitlist mortality now because of those perfusion systems, the transmedic system. So how our Dynameld model would work in a jurisdiction where there's no waitlist mortality, which is wonderful for patients, right? But in our setting where we have a very high waitlist mortality, it is going to vary, and you may have to consider that in models going forward, like the local environmental factors, as well as the philosophy or the society's, cultural values. There also, you may want to place weight on certain factors versus others, right? So, are there any questions? Any other questions from trainees? I hope I didn't lose people. Was I going too fast or? Okay. Oh, thank you.
Thanks very much, Mamatha, for a great presentation. Many of the dashboards that you showed looked like they were exclusively physician-facing or healthcare provider-facing.
Yes.
Are there versions that you've considered for the patient-facing side, so people would be able to see, cardiovascular risk, for example, and the specific factors that might influence their case?
No, that's thanks so much for that question, Patricia. And so we have had patient partners involved in particularly the Dynameld project. Now, the CV risk prediction project, I think, is a particularly useful tool, I think, for patients to feel empowered in their care. For example, if diabetes is the dominant predictor of cardiovascular risk, to provide a simple example, so, Mr. X sees that, okay, diabetes is the main factor, and then, overweight, like BMI greater than 30 is the main factor, then that patient will understand, okay, I need to work on this because this is what is really driving my risk. And then they'll go back and try to address that. Often what we face is that in the clinic, we will say things, we will tell patients, okay, we need to optimize control of your diabetes. We need to do this, but they don't fully grasp, it's not tangible enough. And so what we want to do is give more tangible predictions. For patient facing, right now, this is still in the silent testing phase in EPIC, but we are going to be implementing this into the clinical setting. And then when we do that, we'd like to show this to patients. And so as we do that, we'd want to get patient feedback on the dashboard to see how they feel about the predictions that are made, whether they like this as part of their care or they'd rather not know. I think we'll be doing that moving forward. Right now, it is still going to be physician facing for the time being, but we do plan to, have an exercise with our patient partners to evaluate how best to present this information. I mean, potentially including in the patient portal, so.
Hi, I would love to see it in the patient portal.
You would, yeah.
I would, because I was one of the patients. Every time I would get my labs, I'd go home and plug them all into the app that all the physicians have. So I think that would be great.
Yeah. It depends on how much each person wants to see, right? So
True.
Then we have to ask the individual patient, how much would you like to see, right?
Well, I don't know, it gave me some feeling of empowerment that I am the master of my own destiny somehow,
right.
even though I have these diseases that no one knows how I got or how they work. So at least it gave me some control.
Yeah.
Imagine, maybe, that way. My question though is, you were talking about using AI to evaluate listing. How close is that to being tested or enacted in real life?
I think that's still in the future. What we would need to do is, right now we have just trained on retrospective data. Technically, to do this properly, you would have to, take notes at every listing committee meeting, prospectively train a model. So far, what we've done is kind of a proof of concept experiment. So I was interested in seeing whether, something like this could be feasible. But to do it properly, you'd have to, do it prospectively with, real data. So this would have to be done, using an REB and so on. The one thing, though, is that in the liver transplant selection committee, there's a lot of, or any transplant selection committee or tumor board, there can be, again, as I said, recency bias. Some voices are louder than others and may bias the discussion in a certain way, and then everyone else agrees, so it can be, and then others may not be as attentive to the discussion, particularly if it's a virtual board, so this leads to, I think, some degree of subjectivity, and it's not ideal. So I just wanted to show this as a proof of concept, and I think it does really need prospective assessment through a real RAB-approved study. The other thing is, if we start recording these selection committee meetings, I suspect that it'll end up altering people's behavior, so then we won't even get a real, like real world data, so it could end up kind of changing things already. So, yeah. But I think it's something that we need to consider, because moving forward, I see that we need to do a better job of being as objective as possible.
I agree with you. I also think the 25 to 30% of people who drop out of the list for whatever reason would agree as well.
Yes.
I also see a cost saving to the healthcare system.
Yes.
Let that percolate. I'll talk to you in 2 years.
Sure.
I'll ask one last question, I guess. So Mamatha, like in the Dynameld, you're trying to incorporate things that will help us better predict. And as you know, like the one big limitation a lot of times for the MELD score has been that it doesn't include, frailty,
Exception
sarcopenia, but also that. Was there a reason that's not part of it, or is that something you're looking at, or just lack of
Yeah.
data?
I mean, it's a good question. So frailty and sarcopenia are not part of the Scientific Registry of Transplant Recipients, and it's not collected in a systematic way in many programs. It might be collected in a systematic way where there's a person who has a specific interest in that area. So here probably it would be very systematically collected, but at UHN we have not been doing it systematically. So that's a limitation, and it could also be subjectively assessed. So we had a first version of that model that included ascites and encephalopathy, some of the more kind of subjectively graded symptoms or decompensating features of cirrhosis. And we were asked to remove them because people felt that the reviewers thought that this could end up affecting, like people could game the system to increase the priority of patients on the wait list, et cetera, which was being done in the past, prior to the MELD. One way to get around that might be to binarize, to say 1, 0, ascites, yes, no, frailty, yes, no, sarcopenia, yes, no. But then grading the severity is going to be difficult to do in a very detailed manner. We wanted a large data set to train on. And so the SRTR contains a certain number of features, but doesn't contain these ones.
Yeah, so I guess final session now will be trainee awards and closing remarks by Dr. Mengel.